Namaskar doston, salam, sat shri akal, a very warm good evening. As you can see, it's all foggy here, but we have many hot intellectual ladies here who are going to make this knowledge short really special and hot. So, I am Dr. Seema Pandey, a reproductive medicine specialist by profession and a poet by heart who just is here to introduce you to one new topic, that is robotics role of regenerative medicine and stem cell in our infertility practice. Friends, it's been ages, like infertility is on rise. We had already discussed what all the causes are, and in India, in vitro fertilization as a treatment is considered to be taken when lady crosses her 40s or when her ovarian reserve really goes very down. And what is the way out there? When we start offering them oocyte donation, most of the time their dream for having their own genetic child becomes very prominent, and they just refuse to accept it. So what's the way out for all these females who want to have their own biological child, their own genetic child, but they are not able to? As we are moving forward in science and innovation and recent discoveries, the latest thing in our field is role of stem cell and PRP. Those are those progenitor cells which can make any tissue alive, or which stem cell is a cell which have the capacity to build de novo in any kind of cell it wants to be. So friends, how can it help in our day to day IVF and ART practice? Today we'll be knowing it from none other than the expert who claims to have the maximum number of ovarian ovarian rejuvenation to her name. That is Dr. Lavanya Kiran, one of the very dear darling friend of mine. And please welcome her on stage, on board. Lavanya Kiran, she is from Bangalore. She'll tell about herself. Welcome, Lavanya.
Thank you, Dr. Seema, and thank you, Dr. Anuradha, for this wonderful opportunity. It's a great privilege that I'm amidst such wonderful people here. And I think seeing your face itself, everybody is regenerated. And that brings us to this new topic, regenerative medicine. I'm Dr. Lavanya Kiran. I'm a lead consultant in obstetrics, infertility, and I'm a robotic surgeon. I work at Kaveri Hospitals, Bangalore.
So, Lavanya, to take the stream from here, actually, you can see I am at the airport, so, though my background is virtual, so you cannot see. I've just missed my flight to Hyderabad. I'm looking for another flight. That's why, from here, my co moderator and one of my best friends, this is a program which is from V4 to all of you. And here is our fifth friend, Lavanya. So I'll introduce my friend, Dr. Anuradha Khar. She is going to talk about this important field with our panelists. The leading one is Dr. Lavanya Kiran, and along with Lavanya, there is Dr. Arshi Iqbal, third wheel of V4, and fourth one, Dr. Rajlakshmi Walavalkar. She'll be joining soon. Over to you, Anuradha.
Thank you, Dr. Seema. Good evening to everyone. It's a privilege to, start this program today. We have Dr. Arshi Iqbal, who is from Kota. She's a leading IVF specialist. She has her own center there, and she is highly interested in this field, and she's done a lot of cases also. Now, Dr. Raj Lakshmi Alvarkar, she is head of Cocoon Fertility from Mumbai, and she has trained all along in London, in UK. So, welcome all. I would just tell you about little bit to kickstart that what is ovarian aging. Ovarian aging, it is characterized by a gradual decline in the quality as well as quantity of the oocytes. Now, as Dr. Seema said, that what can we do if what the problem is, that if the AMH goes down, the ovarian reserve falls, the patient cannot produce own eggs and will not be able to have biological child. The basic is this. Now, what can we do? See, we know on one spectrum we have donor egg. That is always there. But it is the dream of every parent to have their own genetically related child. So, what can we do to improve this, get better quality and healthy oocytes out of this ovary? So, there comes the play of rejuvenation or regenerative medicine, what we call it. So, over to Dr. Arshi for the first question.
So my the most common things which nowadays everybody is talking about is regenerative medicine. It is a talk of town, like amongst infertility consultants or specialists, you can say. So my question to Dr. Lavanya is, for a basic, for a common man, what is regenerative medicine? What it includes and what exactly it is about?
So I think it's a very wonderful question, Dr. Arshi. As the technology is kicking forward, we can see that Dr. Seema being in a different place, she's still connected to us. With all the chaos, she's still being there along with us. So that's how the modern medicine is growing. And one such field which is growing now is regenerative medicine. It's a field of medicine where they're talking about how do we use our own cells, and these cells will help in repair. It also regenerates and helps in replacement of a human cell or a tissue or an organ, whichever we are replacing this. So basically, the prime factor here in regenerative medicine, we are talking about the growth factors. We as fertility specialists, we all know that every cell, anything that we are processing, there are growth factors. So wherever we're using these growth factors, it is being used to regenerate, like the name says. Basically, more than saying that it's a very new field, I would rather say it's a field which has existed in innumerable years, especially used by the orthopedician, ophthalm, leukemia, aplastic anemia, spinal cord injuries, arthritis. It's been here for ages. I think it's a gaining focus in a gynecology field, and especially in our infertility field, especially when Dr. Anu mentioned rightly that how the egg aging, and then nobody wants to go for a donor, or preferably they want their own progeny. I think this is how the regenerative medicine is caught up, high demand now, and people are learning more and more through such wonderful platforms. And yeah, regenerative medicine will be the way forward for a lot of us.
So I
Over
also
to
want to
Dr.
ask
Raj.
whether,
Yeah.
okay, Raj, you go ahead.
Dr. Arshi, you continue.
I just want to know, okay, in the field of infertility, this is applicable on what all things? What all can be done with this, either ovary or endometrium? It is how useful it is in infertility.
Yes, in infertility, it is very useful, especially because we all come with a fixed number of oocytes. And we all know through the aging processes, the number of oocytes that we have is only going to deteriorate, it's a time against age. So as the numbers are coming down, and we are already seeing late marriages, either because of personal reasons, professional reasons, delayed childbearing age group is increasing, and they all come to us, or they reach the special fertility specialist much later, where the ovulation inductions have happened multiple times, and by the time they come out, the AMH is very low. So whenever we are talking about poor ovarian reserve or primary ovarian insufficiency or failures, I think these are the candidates where the AMH is much lower, very useful, or they have had a previous IVF where we have oocyte quality is much lesser, or the quality is not good, and thin endometrium, especially if they've had an Asherman's, or the lining is not appropriate for us to do the embryo transfer. These are all the cases would be ideal to go for a regenerative medicine, and where it can be applicable.
That's great, Dr. Lavanya. And I would just like to ask Dr. Raj Lakshmi, you are muted. So,
Mute,
can you just summarize the
mute.
indications for our audiences what all indication you all have been discussing as an indication for regenerative medicine, application of regenerative medicine, especially when we are talking about regenerative medicine,
Hello.
we are focusing on stem cell and PRP. So, Dr. Raj Lakshmi, I would just like you to
Can
enumerate the
you
indications where
hear me?
you are using all these things.
Can you hear me?
Yes,
Can you
yes.
hear me?
Can you?
Okay,
Yes,
great.
Dr. Raj.
Yes.
Yes.
Oh, sorry. Dr. Seema, sorry, could you please repeat your question because there was some a problem at my end, so I missed half of it. Hello.
It
Okay,
is
Dr.
like
Raj was trying
indications
to
for
ask you that to just
indications for the
summarize that
use.
where all it can be applied and whatever has been said till now. Just summarize it.
What
Yeah,
are
yeah.
your indications where you use it?
Where do you use
So
it, if at all?
Yeah, so I have used it more for the lining of the uterus. So obviously, when a patient goes in for an IVF cycle, and you say that the lining is not pressing up as nicely, it could have many reasons behind it. But then by like supplying stem cells or even PRP locally to the endometrium, you could get a jump in the endometrial thickness, and that way you could rescue your cycle. So even if it's like a poor responder, and you don't want to freeze the embryos because you do not know whether they'll thaw well later on or not, and the endometrium is not optimum. That would be my ideal case where I would offer her probably either like a concentrated activated PRP or maybe even stem cells depending on what the case is. So those are the most common indications. Obviously, literature talks a lot about ovarian stem cells and ovarian PRP, and the re-establishment of ovulation afterwards. Um, but then, in my experience, in the few cases that I've done, I see that return to normal menses happened, but I did not necessarily get ovulation. So, that is something that I wanted to ask Lavanya about whether she has a similar experience or has she experienced something different?
So I totally
So
agree with you,
yes,
Dr. Raj. So I think other than fertility,
yes,
one of the
Dr.
social
Lavanya.
reasons.
So
No, no, she's talking. Yeah, yeah, Dr. Lavanya.
yes, please go ahead.
So I think I totally agree with Dr. Raj, where social reasons are also indicated. And like I mentioned, delayed childbirth. So we are also seeing a lot of people who are coming with scanty flow, irregular menstruation, and they're more of around 40 years as well. So in so many of these patients, we have seen there is resumption of regular menses. If they had amenorrhea for a very longer duration post the stem cell, irrespective of the oocyte quality and the IVF, we have seen resumptions in the menstrual cycle. I think that's also a very good indication. And now when we're talking about, so much, attention on the menopausal women, I think this is something very, we should be considering because we all know that postmenopausal, there's a high chance of MI and osteoarthritis and osteoporosis. So stem cell would again be one of the treatments maybe in the future where it will be used for social reasons to reduce the risk for our perimenopausal and postmenopausal women.
Dr. Lavanya, I have one question. Let's come to the technique. And I will be talking specifically about stem cells because stem cell is not so common yet. PRP is very common, everyone is doing in their clinics. Let's straight go to stem cells. How do we do this stem cell rejuvenation of ovaries?
Yeah,
How do we
Dr. Seema
inject?
Dr.
also wants.
Lavanya, Dr. Lavanya and Anu, yes, please, you will go into that detail. Just for clearance of purposes, there are two confusion over here. Like whenever a new therapy comes and resurfaces, and what happens, people start getting lot of, there is lot of hype around it that it is a kind of panacea. It will treat everything. So here, I just want people to understand through all of you what rejuvenation means when it comes to the ovaries and what is the difference. Like, for example, a woman who is born with fixed number of eggs can any kind of stem cell therapy or any kind of PRP increase the number of eggs which we are born with, or can this therapy start regenerating de novo the endometrium a lady has lost either through the disease like chronic infection like TB or repeated multiple curettage?
Okay, we will
Because this
start answering in the.
will
Yeah. So we'll answer in the reverse order. I'll answer Dr. Seema first. So because generally taking it forward, we need to understand when we are coming with the reserved ovaries, there are a lot of parameters that we consider. So that also partly answers Dr. Anu's question as well. So what are the criteria we would look into? It's not a magic wand that we would use it for everybody and say, oh, look, this is where it is, and everybody's going to have a better quality of oocytes, a better quality of embryo. Your endometrial lining is going to become overnight fluffy, where you can just put in the embryos and it's going to work for us. It's not going to be that. So everywhere we need to see what are the kind of patients that we'll be choosing. So do they fit into it? Like the number of oocytes. So if their FSH is very high and AMH is very low, it's very important for us to counsel our patients, telling them, the results may not be good. In such people, like Dr. Raj said, maybe where they can resume their menses, but then it may not lead into a better quality of oocyte. If we are talking about thin endometrium, similarly, if it's very thin, it is balled out, especially in TB. So when patients come with TB, I do not overpromise them. I always underpromise and say it may not work because the pathology is something else. So knowing the pathology, knowing the basics is very important. So choosing the right patient also makes a lot of difference on your success rate. And I think counseling is something very, 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 very important, where we know to use the right kind of patient and always tell them this is an adjuvant treatment, because this cannot be a treatment per se. Because over my experience, we have seen couple of them who have conceived naturally, but then you also have to remember they're that borderline POF where your AMH is still decent. It's just that because of the poor oocyte quality you have done, so they have conceived. Doesn't mean I'm going to go around claiming that they will have natural pregnancies. So I think counseling makes a big crux in success rate as well. Moving on to Dr. Anu's question. Yes, Dr. Anu, I agree that we all started off doing PRP and umpty number of people doing PRP. But stem cell is something that I would say better to get trained in this so that you use the right technology to serve your patients rightly than just randomly doing something about it. So while I got trained, we started doing stem cell. It's very important we also know our limits. So as a gynecologist, I don't want to do my bone marrow aspirations. So I do call an orthopedician, where you need to remember the bone marrow aspiration is done either from the anterior iliac crest or from the posterior, because any marrow is good, but then you can use it from the sternum or the other regions. But then you need to understand we need to get a good amount, so around 30 to 40 ml. So the best thing would be either the anterior or the posterior iliac crest is the best thing. So you can withdraw around 30 to 40 ml. And easy to remember, every 10 ml will give you 1 ml of the processed platelets, where it can be easier. So even if you need to inject into both ovaries or to your endometrium, safer to have around 3 ml to 4 ml would be a better thing. So 30-40 ml from the sternum, it's painful, so the depth is difficult. So easier, pelvic regions. So my orthopedician does it, and it's always safer that you have a qualified person doing this whole process. Jamshedi needle is used, of course, with all the aseptic precautions. So by the time the processing is done, so being infertility specialists, we all are trained in laparoscope. You can either do it through laparoscopic installation, or if somebody's already gone through a lot of other laparoscopic procedures for the evaluation of fertility, it can be done ultrasound guided as well. But then very important, if you're looking at POFs, they will have very streak ovaries. So doing it under ultrasound can also be quite a big challenge for us. So you will have to decide as a clinician, and since we all do our scans, we know what is the volume of the ovaries as well. So it rightly helps you to decide, do you want to do it laparoscopic or ultrasound. Now coming, what happens while I'm putting my port or I'm trying to get my ultrasound ready to instill it. So the processing will start with, you have to run whatever you've drawn. It has to be taken in an apparent falcon tube. So it goes for a centrifuge around 1800 RPM for 12 minutes. Once you get the buffy coat, you take only the buffy coat. That's the middle one. Then you reprocess it. 3200 for 6 minutes. Whatever you get, that is what will be used for installation. So this is how it's done, either laparoscopic or ultrasound.
And Dr. Lavanya, the when once we get that concentrate of stem cells, we have to immediately inject it through laparoscopy,
Yes,
right?
very important.
We
I
should
think
not
that's very
leave it at
important.
room temperature. Yeah. So it has to be
Correct.
refrigerated till the time. I mean, it should be probably a simultaneous process. First, the orthopedician takes the bone marrow, you give it for processing. While it's processing, you put in your ports, right? That's how we do it. And
Yes,
keep the
yes.
ports ready the moment it's ready. And you have a temperature regulated centrifuge for this. You cannot do it in a normal centrifuge. Or if there is delay by some means, you put it in the refrigerator and then. And Dr. Lavanya, what needle do you use to enter the ovaries and where do you inject it?
Since I'm a fertility specialist, it's easy for us because we all have our egg pickup needle, and that's the easiest to do, and it is thin and less trauma to your ovaries as well. Of course, if you are getting your laparoscopic surgeon to do it, or you're doing it in a different center where you don't work for a fertility centers, you can use our laparoscopic needles as well, and that can be used. But then you need to remember that's a little more thicker, so easier will be our egg pickup needle, which is all accessible to all of us.
So you mean to say the cyst
So,
aspiration needle can also be used for
Yes,
ovarian
yes.
cyst as well. Yeah.
Yeah.
so it was an
Lavanya,
excellent way of telling so simply. Yes, Raj, are you saying something?
yeah, no, I just have one more question
Dr.
to
Raj,
Lavanya.
were you saying?
Yeah, no, I just have a question for Lavanya. Lavanya,
Yes,
hi.
go ahead.
So, you talked about bone marrow stem cells, but people do walk-ins with Google principles of adipose stem cells. They say मेरा liposuction करा दो और उसमें से stem cell निकालो, पतली भी हो जाऊंगी, मेरी ओवरी अच्छी हो जाएगी. So, what is your comment for that?
Yes, I think
So, Raj,
adipose.
Lavanya, just a minute for heck of people, as all of us, five of us, we are properly trained in regenerative medicine, so we can understand all these things. But for general public, let's make it simple. And here I just want to intervene. मैं अपने हिंदी दर्शकों को बता दूं कि अभी जब ये स्ट्रीम लगभग खत्म होने को होगी, इस इंटरेस्टिंग टॉपिक को मैं दोबारा से आपको 5 मिनट्स में हिंदी में बताऊंगी. But right now, my question is, there are two things. We, as a physician, treating surgeon, we have to understand that stem cell does not mean stem cell therapy classically. Whatever we are doing in our regenerative medicine, which is applied to our infertility practice, basically, that is related to, we are taking out the stem cell and we are taking the growth factors out of it. Stem cell PRP we are creating. We are not culturing this stem cell so that from where it has to become a license based program where you have to get lot of licenses. Am I right, Dr. Lavanya, Dr. Arshi,
Yes, yes,
Dr. Anu?
yes.
So
That was the
whatever
most important
things
thing.
were,
What is what is the
so this
technicalities
is a kind
regarding
of,
license and who can use it?
yeah, so this is kind of a growth factor aggregation on PRP, and this PRP, how many ways we can make it. So as Raj was asking the same question, so for simplifying it, Arshi, I would like to know how many ways we can make this PRP before Lavanya goes into more detail and Anu is asking.
So first, the easiest way is taking anybody's blood through this any vein and taking 30 to 40 ml and processing it. That is the simplest way which most of the people are doing with PRP, and they say okay, this is PRP they are doing in skin or they anywhere in endometrium. That is the first way out where we collect any venous blood and process it. Second is we take this bone marrow and then process it, and we separate the all the factors, and it is basically a good rich media with factors and PRP. That is a refined form of PRP which is done through iliac crest or through bone. And the third way is adipose tissue, where we suck out adipose tissue either from the thigh or abdominal wall and then process it and extract the all the factors and then inject it. So these are the three which I know.
I have a point to make, which is very important for our doctors to know, that PRP is not an OPD, it should not be done as an OPD procedure. It has to be done hysteroscopically if you are doing for endometrium. Okay, just instilling inside the uterus will not gain much for you. It is not going to benefit the patient as much. So best is, even if you're not doing stem cells, say you're doing PRP, which is the easiest to take and it is very less invasive. So take the PRP and inject it subendometrially via hysteroscopy, because most of us do hysteroscopy for our IVF patients, and particularly thin endometrium, we do go and do hysteroscopy to find out any causes. So injected hysteroscopically, whether it's stem cell therapy into subendometrial or PRP. Dr. Lavanya, am I correct? Since you are the
No, very
expert.
What is
true.
the
No, very true.
right time? Lavanya, I want to ask, what is the right time when it should be done? Because can it be done at any time of the menses, or it has something important? What is the relevant time for doing it?
Yeah. So I'll answer Dr. Raj Lakshmi, Seema Madam's, and Dr. Anu's question first. So here we were talking about, basically, like I started off with the stem cell. We need to understand stem cell are undifferentiated cells, basically. So whichever organ we are going to put into, it will self-replicate and self-renew. So I put into a kidney, it becomes a kidney tissue. You put it into a sperm, you put it into an endometrium, you put it into an ovarian. So where are we getting these things is where is important. So we're talking about hematopoietic or mesenchymal cells. So we're talking hematopoietic, either you can get it from the umbilical cord, from the bone marrow, or the peripheral blood. Now mesenchymal cells are the ones which again come from either umbilical, bone marrow, or the adipose tissue. Now people are getting it from dental pulp, even the menstrual blood. They're removing it from various reasons. So that is how, Dr. Raj, the adipose tissue has come into. These are all technologies. So adipose tissue, again, the processing is more difficult because you have to liquefy it. The duration, all those things are way this thing. And it will take a little longer time that you have to store it and then process and then do it. So here, then you will need a license to get that stem cell and process. Otherwise, this is the easiest what we are doing.
No, so basically my
Excuse
query
me for
was,
my
is,
voice and my flu.
yeah, sorry. So my
Then
query,
So
coming to
yeah,
Lavanya,
Dr.
sorry.
Arshi's question, I think using it appropriately in our infertility cases, when do we use it? It's like using it at the right time. Like, however, when we're doing a laparoscopic, we would choose a phase after 6th or the 7th day till 13th or the 14th day. If you're doing it for an endometrium, I think it would similarly be the same time because your endometrium shedding is over. So post that is always a better time, and you give a month break and redo the process next.
See, the main point is that we do most of the procedures in follicular phase. So better we stick. Also, when we inject this subendometrially, it will take some time to, divide, replicate, or conform itself to the endometrial lining. So she should not get her periods immediately, right? She should have some time wherein it gives time to act. Dr. Raj, you had some
Yeah,
question.
no, no. So Lavanya, my query actually was between blood stem cells, which we know are the best so far, in sort of a grade of preference. Uh, where do adipose and where do like the other site stem cells lie? That was actually my query.
Yeah, that's exactly why I said, you can get it from different regions, but the concentration would be different. So whenever you're using a stem cell or a peripheral blood, your concentration of growth factors is much more compared to the dental pulp or the menstrual cycle or your adipose tissue. So I think the peripheral blood best is the stem cell as of now.
so
So,
that
Dr.
was a
Lavanya, I
very
have a
relevant
small
question.
question. How long do you wait? Like, supposing I have done the stem cell of ovaries this month, and how long do I wait to stimulate that patient for IVF?
So if you're talking into installation into ovaries, minimum is 1 month. Definitely the second month or the third month would be the best to start off our inductions. If you're talking about thin endometrium, 1 month, and then the next month immediately you can start off.
Okay,
So, Dr.
that's clear.
Lavanya, do you mean to say this growth factor or stem cell which you are putting inside, that is going to work on the follicles which are already in antral pool, as
No,
it
they are going
takes
to work on the primordial
as
follicles, and that is what will regenerate.
primordial to antral pool, it takes around 84 days to 90 days. So are we going
Exactly,
to
true.
not wait till then?
No, so we need to understand even the primordial follicles are in different phases. So this is exactly why you need to wait at least for a month. So by the time your stimulation comes and then they are reacting, easily
So
40
those,
45 days are over.
yeah.
Exactly 2 months is best. But in case we all have patients who travel from different regions, then 1 month. Best is 2 to 3 months, and that will have a better primordial follicles getting recruited.
So what my
My
Yeah,
Yeah,
Dr.
so
Ash.
what my deduction
my
was, if your patient is of poor ovarian reserve with poor ovarian quality, that person can get benefited within month. On contrary, a patient who is having very less of number of eggs and we want her to get improved, a chasing of follicles as we do on ultrasound. Similarly, we can wait this primordial pool to grow to antral follicle and we can take longer. So my question was, Dr. Lavanya, Arshi, Anuraj, everyone, like what is the maximum time you wait in these patients before stimulating if patient gives you free choice?
Maximum, I would say not more than 6 months, because there have been not much of studies saying it could deteriorate, because again, like, we're racing against the time. We're already, she's in a poor ovarian reserve, you've done something. So anything from 2 to 3 months, maximum 4 or 5 months, make sure you counsel your patient not to take a break and disappear. Because if she comes back post 6 months or so, the AMH could have dropped again. So I think worst to worst is 6 months. Best would be somewhere between 2 and 4 months.
Yeah,
so Lavanya, does
I will also second the 3 months. Okay, and even though as Lavan has very correctly pointed out, we don't have enough research papers to give you a cutoff. The logic is your like ovulation cycle from the selection of a follicle until ovulation takes approximately 3 months. So if you have given a treatment, then your output is most likely to be best 3 months or 4 months later.
3 months?
So therefore, logic dictates that you wait at least for 3 to 4 months. And obviously, I mean, the jury is out. We need more papers on that. But I would typically counsel for like 3 months.
I have done few cases and I wait generally 3 months. I wait three
So
months.
So,
my question to Lavanya is, what is the
okay.
maximum time where the action can last? Means it is still 1 year the patient can wait, okay, yeah, she will improve. Or what is the last limit where they can see that the results might be there?
See, results may last as long as a year or two, compared to when you're talking about menstruation, because we've had people who have conceived and they come back as well. I mean, post your IVF and they come back to see you with your baby. They're very happy, they're continuing to menstruate. But then if you look into their AMH or FSH, it may not be something, because, over a year it is going to drop down again. So if you're
So
looking
you
at
mean
So
helping her
guys,
conceive, so if you're looking
so
at helping her conceive, then I would say finish it within 6 months. Don't try to
so
wait
so
post that.
this is
basically,
one indication we have talked about ovarian rejuvenation. We have talked enough. Let me take a pause. Till then, you guys think about question on endometrium, thin endometrium. I wanted to share with our audience that whatever we were talking, it is about stem cell and PRP. So these are those undivided stem cell are those undivided cells which can take any shape and form, as I and Lavanya and everybody said earlier, where you put it. At the same time, whenever it comes to ovaries, it is not going to increase or regenerate or make new eggs or new endometrium, but whatever is there, it is going to change it and improve it. Second thing, it can be taken either from hemopoietic sources like blood and from mesenchymal sources like your fat. And third thing, you can put it either in your ovaries. We are talking about infertility here, and योर एंडोमीट्रियम लाइनिंग। तो दोस्तों ये जो पीआरपी और स्टेम सेल का खेल है, ये आपके ब्लड और आपके पेट पर एक्स्ट्रा चर्बी है उसका एक एक्स्ट्रा फायदा उठाने का वो रीजन बन सकता है। आप लाइपोसक्शन करा करके उस फैट से अपने लिए अच्छा स्टेम सेल बना करके, अगर आप सब फर्टाइल है तो उससे हम आपके अंदर स्टेम सेल थेरेपी कर सकते हैं। जोक्स अपार्ट, आपकी स्टेम सेल या पीआरपी को बनाने के लिए हम आपका ब्लड यूज करते हैं, या तो वो हम आपके हाथ से निकालते हैं जैसे आपको ब्लड किसी भी टेस्ट के लिए निकलता है, या आपके बोन मैरो से निकालते हैं। और बोन मैरो सबसे अच्छी आपके हिप बोन से मिलती है क्योंकि हमको ज्यादा अमाउंट में चलती है। फिर उस ब्लड को हम एक स्पेशल मशीन में डाल करके एक छोटा सा पार्ट उसका बना करके आप लैप्रोस्कोपिकली आपकी ओवरीज में डालते हैं, तो उसको हम ओवेरियन रिजुवेनेशन कहते हैं। और जब हम हिस्ट्रोस्कोपी करके एक स्पेशल नीडल से आपके एंडोमेट्रियल या आपकी यूट्रस की लाइनिंग के नीचे डालते हैं, तो उसको हम सब एंडोमेट्रियल पीआरपी या स्टेम सेल थेरेपी कहते हैं। अगर हम कंपेयर करें स्टेम सेल लेने में हम अपने पेरिफेरल ब्लड और ये जो हम अपनी हड्डी से निकाल रहे हैं, तो ग्रोथ फैक्टर्स के मामले में जो आपका ब्लड आपके यहाँ से आ रहा है, स्टेम सेल आ रहा है आपकी रीढ़ की हड्डी से, वो ज़्यादा बेहतर होता है, लेकिन वो एक्सपेंसिव है, थोड़ा पेनफुल है। और इस सब को ये अभी भी एक एक्सपेरिमेंटल थेरेपी है। और इसका मतलब ये नहीं है कि आप 55 साल की उम्र में जब आपको मेनोपॉज हो गया है, आपने ये सोच लिया कि आप जाएंगे स्टेम सेल कराएंगे, आपके अंदर नए अंडे बन जाएंगे और आपको अपने अंडे से बच्चा हो जाएगा। प्रेग्नेंट होने के लिए दोस्तों उम्र आज भी सबसे बड़ी लिमिटेशन है। और ये सारे फैक्टर्स तभी काम करते हैं आपके ऊपर जब आपका एज आपके फेवर में हो। नेचर ने हमें 40 साल के बाद माँ बनने से जो रोका है, उसके पीछे हमारी फिजिकल फिटनेस है। तो इन थेरेपीज को एज एन एडजुवेंट, जैसे हमारे एक्सपर्ट्स ने कहा, इसको एक एडजुवेंट एक्सपेरिमेंटल थेरेपी के रूप में लिया जाता है। ये अभी भी उस जगह नहीं पहुंचा है जैसे ब्लड कैंसर में आपका ब्लड बदल देने से आपका ब्लड कैंसर ठीक हो जाता है। तो दोस्तों इसको बिना किसी बहुत ही एक्सपर्ट, जो हम आपसे बात कर रहे हैं, ये पूरे देश में कुछ चुनिंदा हजार लोग हैं जो ये प्रॉपरली इसके बारे में जिन्होंने स्टडी की है, जिन्होंने कोर्स किया है और पढ़ने के बाद ये ट्रीटमेंट आपके साथ कर रहे हैं। तो आजकल हर व्यक्ति आपको पीआरपी स्टेम सेल ऑफर कर रहा है, उसके ल्योरमेंट में मत पड़िएगा, और जरूरत होगी तो हमारे पास आइएगा, हम बताएंगे क्या करना है।
Dr. Lavanya, I have one important question for our doctors who have logged in. Um, what does the evidence say? Let's talk about, do we have RCTs on this? Do we have studies on it, or do we have just papers and pilot studies? Where are we in evidence for stem cells?
So, yeah, I think it's very important for our doctors and also our viewers, if patients have logged in, that we need to talk scientifically. Now, I think we should never be doing it like it's my experience, this is what it says. I think scientific evidence is very important while we also talk about our experience to back up on, are we talking science? Because now I will not call it an experimental procedure anymore because we have enough data across the world. I'm not just talking about outside the country. Even we have several Indian studies, also more than 7 to 8 Indian studies published across the world. We have a lot of people who have moved above stem cell. They're talking about ovarian tissues being regenerated. So there have been several studies, more than 40 or 50 papers have been published on this. So it's not right for us to call it experimental procedure anymore. And I'm glad to share on this platform that one of our studies also, we have 2 studies which is in the peer review already and being going to be published in the international journal. One is on ovarian regeneration. We've done a study on 85 patients, and thin endometrium as well. We have done around 65 patients. So both are for publication. So yeah, well, I think we have enough journals and studies now to support what we are doing.
So I think we are in the middle, probably. We have some evidence. We need more robust evidence on it. But whenever a therapy gives you that extra pregnancy, I think we can try it out in our centers, because unless it is done on a lot of patients and some benefit, I think it's worth it. Does the What's the opinion of all other?
I have personally seen very good results in my patient, but the only thing is judicial selection of the patient is the most important key
Absolutely.
to success.
Yeah.
Absolutely.
Patient
So
do,
here,
because I'm from
Yeah.
Rajasthan, and here tuberculosis is quite endemic, and few patients are there
Arshi,
who are
I
having.
wanted to ask Arshi, that was my question from you. Since apart from being like our population, there are many people who accept even oocyte donation, no, and they are ready for to go for oocyte donations ART cycle. But our limitation becomes, since we come from the North Indian side, where chronic infection, especially tuberculosis, is very rampant, and our limitation becomes their thin endometrium. So what are the ways where how you are using this PRP and stem cell in all these patients, and what was your experience? First of all, I would like to know from you, and then Raj, Anu, and Lavanya, as they are living in metros too, and I will share mine too.
Yeah, Dr. Seema, this is very true that in our area we are having a lot of tubercular patients who are having their endometrium affected, and so many patients with irregular endometrium comes to us, and most of them are repeated IVF failures. So in these patients, I usually try with PRP, and I think in last 1 year I have done n number of cases, and the results are very good. And the only thing is I do at least for 2 months in two different cycles, and then come up with the main cycle. And if the endometrium is really very poor, so initially I start with estrogen priming of the endometrium, and after 1 or 2 months of estrogen therapy I do PRP along with it, and then for after 2 months of PRP, two cycles, then I start with my main induction, and I too have got beautiful results with it. But the main thing I'll say, it is only the patient selection, because in a patient where you are not having any endometrium and the endometrium is too thin, there the results are not good. But irregular endometrium, definitely a nicely done hysteroscopic operation with PRP installation, definitely I have seen good results, and the bloods, even the endometrium goes up to 8 or 9 mm with a good flow.
So
So
very
this
quick
is,
opinion from all of you as we are ending towards the end of this show
Yeah. So
Yeah.
regarding
again,
thin
I
endometrium as a man,
okay.
and PRP
Anu goes.
intrauterine versus subendometrial.
Dr. Raj.
Okay, so we know from all the studies and from the few cases that we've done individually that subendometrial PRP is always going to give you a much better outcome than just insulin. Now, subendometrial PRP, not everybody is going to be able to afford a hysteroscopy, and therefore the cost factor comes in. And therefore, maybe first line would be to have an activated PRP institution, look for the response, and if the patient is giving you a moderate response to something, or you really feel that you've like given two different types of estrogens, you've gone up to day 14 and you're still struggling to cross a 6, then maybe this is a patient in whom a subendometrial activated PRP or Capsule is like it is going to be the right choice to go ahead with. So I completely second Ashi's opinion that selecting your patient very keenly. So only on one cycle of getting a bad endometrium, don't jump in. Maybe track her for a couple of cycles, give her different stimulations, try a modified natural, try like a mild stimulation, see what's happening. Your mild stimulation could also be a simple letrozole stimulation, and you come to grips with the endometrium. Take a look at the blood flows, take a look at the pressures. I know pressures are out now because people don't believe in them anymore. But old timers, I think I like call myself an old timer when it comes to doctors. Um,
I would
so yeah,
like to add, endometritis is also very common. So simultaneously covering up the endometritis factor is also
okay.
very important in thin endometrium, because
Yeah,
patients
I
are
also
chronic
have
and
good experience with the hysteroscopic PRP installation. But where people cannot afford, something we have to offer. So what I do is I call the patient and do little scratching of the endometrium, which I had asked an expert from abroad, that supposing we are not able to, so they told me that, do little bit endometrial scratching, mild endometrial, and then instill. That works better than just simple intrauterine
So
installation.
this
So
is done
that,
on which part of your menstrual cycle?
Normally day 8, day 9. Day
This
8, day
Anuradha
9 is
one,
the
right?
Just
ideal.
hold on. Yeah, yeah,
day,
yeah.
day
And
9,
now
day
tell.
10.
He's saying
So she will
he
again
can't
start
see
bleeding
us.
in.
Dr. Lavanya has not seen anyway.
Lavanya got
Yeah.
Okay,
locked up.
okay, okay. So yes, girls,
So
she is coming. She had some network issues. I would like to share one experience of mine. Two patients of mine who have been declared to be totally unfit for having their own womb for their conception. They were advised surrogacy after 4 or 5 IVF failures, and then uh, we tried to do. They came for this surrogacy, and in meantime surrogacy was banned, and we started working on them through multiple hysteroscopic subendometrial installation at least 6 weeks apart, minimum 6 week. In fact, 2 I did 6 months apart, just on request of the patient, because he couldn't afford surrogacy going somewhere else. And both these patients I left for 3 months. Whatever other issues they had, I had treated. And you won't believe that both these patients I transferred them in natural cycle without any hormone, and uneventful 9 months pregnancy, both of them have delivered. All said and done, every patient cannot be proven that lucky. And if we compare, though I agree that Raj is saying it is costlier when we do it hysteroscopically, but that is the correct way of doing it. On contrary, Dr. Arshi Iqbal has invented a new approach where she goes intrauterine ultrasound guided with her needle and does that everybody cannot do. We would like to hear from her. But if you really want to do it, you can cut your cost of the surgery, you can cut down your fee, you can encourage the patient to spend little bit more and go for the standard proper procedure at least once. And second time when you are instilling intrauterine, that might work better. That is my say. I think Dr. Anuradha will agree to it. And Dr. Raj,
Yeah.
please tell us quick. Dr. Archie,
Yeah.
please tell us quickly your new invention which you are doing nowadays. Welcome back, Dr.
because
Lavanya. We have
uh,
2 minutes
Sorry.
to
Yeah,
because
I
finish.
could.
I have tried in my few patients and they have conceived, so I feel it can work. And both there were few IVF failures, two cycle IVF failure, and previously ATT has already been taken with an endometrium, and the patient was non-affordable. So I tried transvaginal with my this pickup needle with all the cares and tactics, and I tried to insert it, and I used a TVS probe and see where it is going, and I injected it into the myometrium. Although it was tough, it was quite hard, but still I could do it. And that patient had result because she was no money, so hysteroscopy she was not affording. So I tried it and it worked for me. So maybe in future, I have done just two cases with this, and
So
maybe I'll.
maybe we need more cases and we can build up a paper and present it.
Yes,
So,
yes, yes. So
so the
Dr.
girls,
Lavanya.
five knowledge shots we start from Dr. Lavanya. What are those 5 shots you are going to give to these patients where your regenerative medicine works the best?
So, before going into regenerative medicine, I would tell people plan your pregnancy at the earliest. So,
yes,
don't delay
Very
That's the
good.
best.
pregnancy unnecessarily. Of course, if you still want to delay for some other reasons, you go preserve your oocytes. Then you can always, when you meet your Mr. Right person or you think is the right time, I think that would be the ideal situation always. But unfortunately, for whatever reasons, there has already been a delay and then you want to first approach the qualified fertility specialist, and that's the best thing that you can do. Second, you don't have to be worried. Of course, very important for our fertility doctors also to practice very ethically. Consent And the communication is very important, and documentation also very important, and not over promise when you try to make the patients understand. And it's also very important for us to tell the best result will be a oocyte donor, but if somebody insists to go for a regenerative medicine, the stem cell processes, the percentage may be lesser but definitely works well. So POF, POIs, premature ovarian failure, insufficiencies, thin endometrium, definitely way forward. If you're looking at your own progeny and you want a baby sitting inside your uterus, yes, this is where you will have to be going for. Of course, it's also been there for male fertility. I have not seen much of results. Maybe another palin on male fertility would be good, but they're also something to be considered. Yes, and this is a growing field. By growing field, I also say scientifically practicing evidence based is the best.
You're
Uh,
not audible.
do
So
I
I'll
go?
say,
Yeah.
Three
so
Ashik,
shots.
my take home is, yeah,
three
eat,
shots, five is too much.
eat, eat healthy, very, very important. Sleep adequate. You should have adequate sleep and good lifestyle, exercise regularly so that you can push away these regenerative
Great.
conditions.
Dr. Anuradha, your shots.
Yeah. So my first shot is careful selection of patients. That is very important.
Great.
For that, I would say when you do ultrasound, there should be few antral follicles visible. Don't do these kind of rejuvenation and expensive treatments when you can't see even one follicle where there is that homogeneous zero follicle ovary. It won't work on that. So that's very important. Second, on PRP, I would say intrauterine insemination. I mean, intrauterine installation.
Installation.
Try to avoid it if cost is not a factor. Do subendometrial hysteroscopic injection of PRP. Third, stem cells, if you are doing in your place, the centrifuge has to be temperature regulated. These stem cells are very, very frail. They will not work whatever sudden. You cannot do it on a normal centrifuge where you centrifuge for serum separation and all. Please do it by a good centrifuge which is temperature regulated. These are my shots.
And how many
Under one roof.
shots Raj is going to give?
We can do five
Three
shots, I
again.
think.
Okay, no, no, no. We have to wind up. We are already running over time.
Uh,
So my first point is going to be, do not fall into the trap of preparing your stem cells somewhere else and then transporting them to your clinic, because you have a
Yes,
very
very
limited
important.
time in which they are going to be acting, and you are going to have a temperature insult to them, you are going to have a transport insult to them, because we know that stem cells is agitated in the tube. Also, you could have loss of those cells because the cells are very, very delicate. So that is my first thing. So there are a lot of people that come and meet you and say, we will prepare stem cells, we will send them with like a transporter and this and that. Please don't fall prey to it, and that is for all my fertility colleagues. That is the first one to see. The second thing to see is obviously patient selection, patient selection. There are going to be patients who are going to be giving you a very, very successful outcome, but selecting them correctly, counseling them correctly, and counseling them for both good and bad things. Get them like prepared to, hope for the best, be prepared for the worst. Because at the end of the day, what you consider as a success and what the patient considers as success are completely two different things. For you, Andrew's rising will be a great success. For you, her menstrual cycle completely regulating is a great success. Your like stem cells have worked. But in that patient, if her ovary is resistant to actually producing a good quality egg, okay, then that comes.
So,
And lastly,
so
even if you are doing it
yes.
for ovulation, even if you are doing it for
So,
ovulation, we have to tell the woman that at her age of 45, 43, whatever age she's doing it, the stem cells are still not going to give her the quality of an egg of a 24, 25-year-old. And that is something that has to be drilled in. Because of the age, there is going to be some sort of a cellular deterioration that you will get. So you might get eggs, but you might not end up getting embryos from those eggs. And these are three very, very important things from us, from our point of view as doctors.
so Raj, I
So
am
yeah,
stopping you here. Now, yes. So we've got all the knowledge shot for our doctors. अब हमारी अपने दोस्तों और पब्लिक के लिए दोस्तों रीजनरेटिव मेडिसिन और स्टेम सेल एक नया उभरता ब्रांच है। जैसा हमारे एक्सपर्ट्स ने कहा, ये उतना नया भी नहीं रह गया है, लेकिन अभी इतना कॉमन भी नहीं हुआ है कि हर व्यक्ति इसको अफोर्ड कर सके, या हर व्यक्ति अफोर्ड तो कर सकता है, लेकिन हर क्लिनिक इसको ऑफर कर सके। इस ट्रीटमेंट को पाने के लिए आपको एक स्पेशल एक्सपर्ट के पास जाना पड़ता है। ये बहुत ही सिंपल है। इसके साइड इफेक्ट ज़्यादा क्या कुछ भी नहीं है, वो आपकी बॉडी के अपने टिश्यू से लेकर के बनाए जा रहे हैं। कुछ रिसर्चेस चल रहे हैं वो, जिसमें कुछ स्पेशल मीजेनकाइम और ये बहुत एडवांस लेवल की जो स्टेम सेल थेरेपी है वो आपको नॉर्मली ऑफर नहीं की जाती है इनफर्टिलिटी में। तो हम अगर इनफर्टिलिटी के ट्रीटमेंट में देखें तो ऐसा कुछ भी नहीं है पीआरपी और स्टेम सेल में जिससे आपको किसी तरह का साइड इफेक्ट होने वाला है। लेकिन ये समय से बच्चा करने का विकल्प नहीं है। आपको अपनी फर्टिलिटी को पोस्टपोन करने का एक विकल्प नहीं है। अगर आपने अपने ऊ साइट नहीं फ्रीज किए, या आपने समय से इसलिए शादी नहीं की कि जब मन करेगा कर लेंगे, या बच्चा नहीं किया, तो आप आगे चल के स्टेम सेल की बदौलत अंडे बना के बच्चा अभी नहीं पैदा कर सकते हैं। ये आपको एक साथ में एडजुवेंट की तरह एक थेरेपी है, जो अगर आपके एंडोमेट्रियम में कुछ कमी है, अगर उसमें चोट लग गई है, उसकी ग्रोथ अच्छी नहीं हो रही है, उसकी ब्लड सप्लाई अच्छी नहीं है, उसकी थिकनेस अच्छी नहीं हो रही है, तो उसमें कुछ इम्प्रूवमेंट ला सकता है। अगर कोई और बीमारी नहीं है वहाँ पे तो, और आपकी ओवरी में जैसा हमारे एक्सपर्ट्स ने कहा कि कुछ अंडे रह गए हैं जो अच्छे से काम नहीं कर रहे हैं, या अभी कुछ चांस बाकी है, वहां पे डाल के एज एन experiment, if you don't want to go for donation cycle straight away, you can try this. So ये सब थेरेपीज को हम एक अपने लिए अपनी नेचुरल चीजों के साथ एक एडजुवेंट के रूप में एक बून की तरह ले सकते हैं, लेकिन इसको सोलो ट्रीटमेंट नहीं मान सकते हैं जब तक कि हमारे रिसर्चर्स ये प्रूव नहीं कर देते हैं कि ये कभी भी कहीं, और या वो दिन आ जाए जिस दिन या तो हम अपने अंदर जो एग्स है उनका खत्म होना रोक पाए, या हम नया बना पाए। तब तक बेस्ट ऑप्शन इज टू गेट मैरिड ऑन टाइम एंड गेट your child in time. If you can't, freeze your eggs. Thank you so much. आज के लिए
I have
इतना
one
ही।
last point, Dr. Seema.
Yes,
I would like to
please do.
congratulate Dr. Seema, Dr. Raj, Dr. Arshi, Dr. Lavanya, and myself on completing our fellowship in regenerative medicine. We are now we are we can do these procedures in our respective centers, and I would like to congratulate. And my dream, I will tell today, is to produce one viable fertilizable egg in a lab. That's my dream. One day it will come
And
true.
at the
Amen.
Amen. We'll all say Amen. And at the same time,
Um,
I would like to thank our expert, Dr.
Thank you.
Lavanya Kiran, who
thank you.
unconditionally, without even asking, within 12 hours is in the show, and she has just shared all the pearl of wisdom and knowledge with us. And I thank my V4 for continuing this one more day program. Till we meet tomorrow, good evening, Shabak Khair, bye bye, Shubh Ratri. अपना अच्छे से
Thank you
ख्याल
Good
so
रखिए,
much.
कीजिए,
Before we before we log
प्रे
off,
कीजिए मेरी फ्लाइट मिल जाए कल।
yeah, we will
night.
pray for you and congratulations for this wonderful knowledge shots that you're sharing with all the public and our doctors. I would pray that you, Dr. Anu, all of you do very well in ISAR as well. Wishing you all the great luck and requesting all my other friends who've logged in to make sure Dr. Seema and Dr. Anu, wins in ISAR and gives us more of knowledge shots to the public, and giving the right knowledge, I think, is very important. And this goes with leaders like you.
Thank you, love.
Thank you so much, Lavanya. That gives me courage to ask people, please, please bless us with your votes. Your vote is precious. I'm contesting for the post of librarian ESAR, and my friend Anuradha Khar is contesting for the post of managing committee member ESAR. अब मेरी दो दोस्तें
Thank
All
you
the
कहेंगी.
so
best.
much.
We're all in your support.
Thank you
So
so
Thank
much.
you. Love you all.
we want everybody in support of Dr. Seema Pandey and Anuradha. It's a humble request to please vote and support these two candidates. They are worth it.
Absolutely.
Bye bye.
Dear doctors, if you think we are worth your vote, please vote for us. And we are going to do good job if we come into ISAR. Thank
You
you
will
so much.
100% do a
You will,
marvelous.
yes.
I think everybody should vote
Marvelous
for
job.
Thank
We
you.
will share more knowledge like this with all of
Yeah,
you.
knowledge shots.
Yes.
Okay, bye-bye.
Thank you.
you.
Take
Good night,
care.
Great. Bye
See
everybody.
you
bye.
Thank
till
you.
good night till tomorrow. Bye bye.
Live stream chala gaya. It's still live, I think.